Welcome to Board Pearls. This is episode 1 of 4 of the GI Emergencies chapter, in the Special Populations and Acute or Supportive Care module. In this episode, we cover massive upper GI bleeding as a resuscitation problem, restrictive transfusion, massive transfusion protocol, anticoagulation reversal in the first hour, pre-endoscopic erythromycin, and the recognition traps of aortoenteric fistula and failed hemostasis. Massive upper GI bleeding runs on a clock. The clock starts when the patient arrives. The decisions made in the first hour shape the next 24, and the wrong decision applied confidently is worse than no decision at all. The teaching for this episode follows the timeline the patient is actually moving through. Massive upper GI bleeding is a resuscitation problem before it is an endoscopic problem. The 4 stigmata, the PPI strategy, and the varicose bundle all live in the upper GI bleeding chapter. What this episode adds is the resuscitation that precedes those decisions and the parts of the first hour that the boards test as their own answers. The transfusion target is restrictive. The landmark trial randomized patients with acute upper GI bleeding to a restrictive strategy, a hemoglobin trigger of 7 and a target of 7 to 9, against a liberal strategy triggering at 9. Restrictive 1, with lower mortality and less rebleeding, and the cirrhosis subgroup drove most of the benefit. That last point is the mechanism. Liberal transfusion in a cirrhotic with portal hypertension reopens partially clotted vessels and expands portal volume, which raises variceal pressure and starts the bleed again. Overzealous resuscitation in any bleeding patient raises mean arterial pressure across a fresh clot and dilutes the platelets and clotting factors the patient is making at the bleeding site. Restrictive works because permissive hypotension protects the clot. 2 qualifications hold. The patient with active acute coronary syndrome is transfused at 8 rather than 7 because the same anemia that protects clots starves an ischemic myocardium. And the patient with active uncontrolled hemorrhage in front of you is transfused empirically based on clinical assessment because the laboratory hemoglobin lags the real-time loss by 30 to 60 minutes. The number you draw is from before the most recent surge. The second early decision is massive transfusion protocol activation. The threshold is anticipated need over 10 units of packed red cells in 24 hours, or 4 units in 1 hour. The protocol delivers a balanced 1:1:1 ratio of packed red cells, fresh frozen plasma, and platelets. That ratio reproduces whole blood and avoids the dilutional coagulopathy that crystalloid-only or red cell-only resuscitation produces. When a patient loses a whole blood volume, receiving red cells without plasma and platelets dilutes the clotting machinery and prolongs the bleed. Calcium repletion is the undertested adjunct. Citrate in stored blood products chelates ionized calcium, and ionized calcium is required for coagulation cascade activation. Rapid transfusion drops ionized calcium fast enough that repletion belongs in the protocol itself rather than as an afterthought. Anticoagulation reversal runs in parallel with the transfusion. The full agent-specific algorithm lives in the endoscopy practice chapter, but the short version belongs here because it is part of the first hour. Warfarin reversal in life-threatening bleeding is 4-factor prothrombin complex concentrate, not fresh frozen plasma, because PCC reverses faster and carries less volume burden in a patient already being volume resuscitated. Vitamin K is added for sustained reversal but is not the acute window answer because of its 12 to 24-hour onset. Dabigatran is reversed with idurucizumab, 5 grams intravenously. Apixaban and rivaroxaban are reversed with andexanet alpha, with 4-factor PCC as the alternative when andexanet is unavailable. Reversal pairs with intervention rather than delaying it. Endoscopic hemostasis can proceed with INR between 1.5 and 2.5 alongside reversal. INR above 2.5 gets reversed before endoscopy in most situations. The principle is that you do not let the INR hold up the EGD when the patient is exsanguinating. Pre-endoscopic preparation has 2 specific pieces beyond IV PPI. Erythromycin 250 mg intravenously over 20 to 30 minutes, given 30 to 90 minutes before endoscopy, improves visualization by promoting gastric emptying through motilin receptor agonism. Blood and clot clear from the gastric lumen so the endoscopist can find the source. The benefit is reduced need for second-look endoscopy and shorter length of stay, not mortality. Tranexamic acid is not given. A large trial showed no benefit and an increased risk of venous thromboembolism. The reason TXA fails in upper GI hemorrhage is that this is arterial spurting from a discrete vessel that requires mechanical hemostasis. It is not the fibrinolysis-driven coagulopathy that antifibrinolytic therapy is designed to address. TXA is the right tool for the wrong problem. Airway protection with endotracheal intubation is the answer in several scenarios. The encephalopathic cirrhotic with active hematemesis, massive hematemesis with aspiration risk, hemodynamic collapse. Any patient who cannot protect the airway during expected high-volume blood, return at endoscopy. The board-favored move is elective intubation before EGD rather than waiting for an emergent airway in a positioned patient with blood in the field. Endoscopy timing for non-variceal upper GI bleeding is within 24 hours of presentation. A randomized trial in patients with high-risk bleeding scores compared urgent endoscopy within 6 hours against early endoscopy at 6 to 24 hours and found no significant difference in 30-day mortality, rebleeding, or need for intervention. The instinct under stem pressure is to read sicker as more urgent, but pushing the EGD earlier did not help. Variceal hemorrhage gets endoscopy within 12 hours, and the full variceal bundle lives in the upper GI bleeding chapter. Pushing endoscopy below 6 hours is reserved for ongoing massive hemorrhage that cannot be stabilized, or for suspected aortoenteric fistula in a patient with a prior aortic graft. Aortoenteric fistula is the high-yield trap inside the massive UGIB recognition stem. The classic presentation is a herald bleed, a self-limited episode days to weeks before the catastrophic hemorrhage in a patient with a prior aortic graft. The fistula classically communicates with the third part of the duodenum. CT angiography looking for periaortic gas or contrast extravasation is the imaging step that precedes both EGD and operative repair because confirming the diagnosis changes the operation. Salvage angiography by interventional radiology is the threshold when endoscopic hemostasis fails despite appropriate dual therapy. The two arteries that get embolized most successfully are the gastroduodenal artery for posterior duodenal bulb ulcers and the left gastric artery for lesser curve gastric ulcers. Those are also the two locations where endoscopic hemostasis fails most often, with rebleeding rates near half for posterior bulb ulcer and roughly a third for lesser curve gastric ulcer. Both arteries course immediately deep to a relatively thin ulcer floor, which is why endoscopy struggles and why angiographic embolization works. So the upper GI hemorrhage bundle has a single shape, resuscitate to a restrictive target rather than a liberal one, because permissive hypotension protects the clot. Activate the massive transfusion protocol at the balanced ratio and remember the ionized calcium that citrate chelates. Reverse anticoagulation in parallel with endoscopy rather than as a delay, with prothrombin complex concentrate for warfarin and the agent-specific antidotes for the direct oral anticoagulants. Clear the field with erythromycin so you can see the source, protect the airway when blood return threatens it, and recognize the herald bleed of an aortoenteric fistula and the two arteries where failed hemostasis send you to interventional radiology. The next episode takes the lower GI and ischemic emergencies. Acute lower GI bleeding with its hemodynamic split between CT angiography and colonoscopy, colon ischemia with pain before bleeding, and acute mesenteric ischemia, where lactate lags and the four etiologies each demand their own intervention. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 1 of 4 of chapter 31, and I'll see you in the next one.